external disclosure. So actually, I'm an HPV surgeon. I believe that the curative resection is the preferred treatment for ECC. But the fact is, the majority of patients are in this stage without diagnosis as ECC. So at that time, surgical resection is not achievable. So conversion therapy can be used to change the unresectable ACC into resectable disease, and it's a breakthrough treatment strategy. The unresectable ACC can be divided into two groups. The first group is we call oncological resectable disease, which means surgical resection is not possible due to tumor progression. For example, the microvascular invasion, macro lesions. Another group is surgical resectable, unresectable. That means surgical resection is contraindicated due to insufficient future liver remnant volumes. So for that patients, we will try some ways to increase the future liver remnant. So actually, for what about what's the definition for the adequate FLR volume for the liver resection? For normal liver, most time FLR must be more than 25%, and for the patient with cirrhosis, most commonly in China, as the main cause of ACC in China is hepatitis D. So FLR must account for more than 40% of the total liver volumes. Recently, we used several ways to increase the liver volumes, for example, PBE, A-PHPBA. Today, I will introduce the liver venous deprivation and radiation appendectomy. Okay, let's talk about PBE. We believe that it's a very classical and safe technique for to increase the liver volume, but we have to admit that the speed is not very satisfactory for us. Sometimes patients have to take more than 40 days, and the tumor may progress. The major mechanism for the liver regeneration of PBE is hepatic arterial buffer response. Let's talk about the ALPS. We feel that it's a breakthrough in hepatic surgery for rapid liver atrophy. It has higher resection rates and higher median FLR increase, but we have to admit that it may have higher initial complications and mortality. It is suitable for very selective patients and very experienced surgeons. So, which one is better? Yeah. So PBE is safe and it's easy and safe, but about almost 40% of the patients fail to achieve surgical resection after PBE. And what about the ALPS? We have the ALPS, which almost 15% of the patients will develop liver failure after the first stage of the procedure. We also observe some patients the liver volume will not increase for some patients, especially for patients with severe cirrhosis. So we do some scientific research. We found that inhibition of the TGF-beta1 accelerates regeneration of fibrotic livers in rat models. How to balance the rapid FLR growth with the complications and mortality? We will have a better way. Now let's talk about the LVD. So in PBE non-responders, adding hepatic embolizations can further increase the FLR. So when we do the PBE and hepatic embolization at the same time, we call it LVD. First, normally we do the puncture of the portal vein and find the right hepatic portal vein and do the portal vein embolization. Next, we can do the puncture to the right hepatic vein and do the hepatic vein embolizations. Actually, there are several ways to find the right hepatic vein cutaneous puncture or through the jugular vein. Sometimes the right hepatic vein application is not enough because we combine the middle hepatic vein and right hepatic vein application for the extended LVD. So what's about the result of LVD? So, according to this publication, we can see that the surgical resection rate was 92% in the LVD group. This is much higher than the 68% of PVD group. And the internal of the procedure was shorter in LVD group. Actually, to our knowledge, we can't find the data directly compare the A-PHPBA and the VRD, which one is better. But according to the network analysis, compare the effective ELPS and PVE, we can see that the LVD almost got similar LR hypertrophy and R0 resection rate, and then have a very, very low 90-day mortality. So, at this time, I want to introduce this very encouraging data of LVD. Up to that, we view that it is the largest cohort in the world. The data shows the technical LVD success rate was almost 100%. So our group found to do some research about can we combine the taste and LVD together. Why we combine these? We want to use the taste to control the tumor growth for the liver hypertrophy. Some experts think this may be very dangerous because of the very severe failure after we do the taste at the same time. So we choose the precision taste. So our central analysis, the 12 patients undergoing combined LVD and taste, we do that is a safe, very safe way. And the follow-up study of 23 patients confirmed with the feasibility and safety of taste plus LVD. In our group, we found 82% patients achieve resectable FRL volumes, and it's very safe. No patients suffer from severe liver dysfunction. So our data was awarded by the excellent members of China Association of Science and Technology, also very highly cited. Let's show you one of the case. So this gentleman is 44 years old, but LP increased a lot. But we can see the tumor volume is quite huge. Fortunately, there is no vascular imaging and no metastasis. So we do the taste combined LVD. First, we do the taste, the precision taste of the tumors to control the tumor growth. Then we do the PVE, and we do the cutaneous puncture. We will find the bottom vein system and find the right bottom vein, the position. Then we do the transcangular vein. Find the right hepatic vein to do the amplification of the right hepatic. So 3 weeks after the scan of 3 weeks after LVD, and we can see the left lateral increase from 363 millimeter to 664. Then we do the right transsegmental hepatectomy. You can see the receive device for the right hepatectomy. So the tumor size is more than 23 centimeters. This is another case. This female is 64 years old. You can see that the LPM actually increased a lot. This tumor volume. They very big. We do the taste. Then we do the taste fund. Basically, actually supplying the tumor and the PVE. And we find the rat hepatic vein and put the device on the rat hepatic block of the device flow. 3 weeks after LVD, the red level increased a lot. Let me do the operations. And the vision very good. So if there are any other interventional clause can increase the FR hypertrophy besides LVD, so what about the Y90? The Y90 administration shared techniques, technical similarity with case procedures, but the mechanism of action of Y90 differs from case. So some scholars believe that Y90 can achieve the dual therapeutic effect of FR increasement and tumor control. That's very likely, but we have to say that the media of degree hypertrophy for the Y90 varies a lot. Some people published only 4%, and some publications show very good effect of the liver hypertrophy up into the Y90. So we still need a lot, several data to support that. Anyway, Y90 has been recommended by both domestic and national guidelines for ACC conversion therapy. So to do a sum up, the conversion therapy, our purpose is to downstream or increase FLR, enable resection for unresectable ACC, improve the outcome in advanced stage of the ACC. There are several techniques to increase FLR, PBE, LPPS, and the RED. We have to say that there's these techniques have advantages and disadvantages, and we have to consider the benefit for the patients. And the case plus LVD, we believe that is very safe and good way to increase the FLR. And to the limited data in our center, about 80% of the patients will be a good candidate for the. That's all. Thank you.
Thank you, Professor Wang, for this quite complete review of all the technical we have before to increase the future liver writing volume. This topic is open for discussion. Any question from the audience? It's please.
Thank you very much for your nice presentation. So my name is Tung from Vietnam, and I have two questions. First, as you saw, the LVD have more effective. First is faster, and second is greater than cultivate amylase. Why is that? What is the mechanism? That is the first. And the second question is, as I know, there are several types of liver venous division. First, we can perform the hepatic vein embolization and the portal vein embolization the same day. That we call the simultaneous. And another technique, we can perform the portal vein embolization first, and after a few days, we perform the hepatic vein embolization. That we call the sequential PVE and FE. So, in your opinion, is there any difference between the simultaneous or sequential PVE and FE? Thank you very much.
Sorry, can you repeat your first question? Have me some.
The first question is, what is the mechanism of your result?
Oh yeah. The mechanism for LVD. Yeah, it's a very good question. Actually, we have do some scientific research about that. Actually, it's very hard. It's very hard to make the animal models for the LVD. But we get some samples from the human being. We do some transpiration genomics about what happens during the liver hypertrophy. Mainly two mechanisms for the liver hypertrophy. One is the regeneration. Another one is the enlarge of the hepatic cells. Two mechanisms, briefly speaking. The second question is that's very interesting. Is in the past we do the PVE, but we found some patients the liver upstream is not very good for the only way of PBE. Then we do the hepatic embolizations to increase the FLR. But nowadays we only do the LVD. We stimulus PBE plus HBE. We believe it's very safe. Frankly speaking, some patients may suffer from some temporary liver dysfunction. The ALT, LC will increase a lot. But about 3 days or 4 days later, it will get better. So the liver function will get normal within 1 week. And then no patients suffer from kidney dysfunction. Very safe.
Thank you very much.
Okay, Professor Clark.
Thank you. Thank you for your nice presentation. This is David from Cleveland Clinic. One of the biggest concerns for THCE plus LVD is the development of abscess because there's no blood going to that area. What is your rationale of doing all of them together? And how do you prevent abscess from development?
Yes.
Because,
thank you. That's my concern. When I've tried this technique in my first patients, actually I'm HPB surgeon. I'm not an interventional radiologist. I talk about this technique in detail with my colleague. They give me some confidence that for their perspective of the interventional radiologist, they do that we do the precision case, not the case. We only block the very small vessels, the artery vessels to the blood, to the tumors, not the right artery, not the trunk of the right hepatic artery. So we think that if we block the trunk of the right artery, it's a disaster for the patient with automated long blood supply totally. We only block the branches of the right hepatic artery to supply the blood flow. And after we do the liver resection, we can observe some necrosis, and some of the patients suffer from fever, but we haven't observed the abscess for patients.
do you have any antibiotic prophylaxis protocol? You can ask.
Yes, we will use for 3 days. 3 days.
Okay, because time limit, we'll cross this topic.